today's speaker, house cleaning items. If you would like a certificate of participation to submit for continuing education credits, please email sales@bestnotes.com. Also, please mark your calendars for May 17th at 1 p.m. Eastern for our next webinar with Dr. Clifton Mitchell, who will be talking about legal and ethical considerations with your clinical documentation. Now, it's my pleasure to introduce Dr. Michael Miller, who is a highly respected board-certified addiction psychiatrist. He is a distinguished fellow of the American Society of Addiction Medicine and a distinguished life fellow of the American Psychiatric Association. He's also a world-renowned lecturer who we have the pleasure to hear from today. If you have any questions for Dr. Miller, please enter them in the chat. And thank you for your time, Dr. Miller. Please take it away.
Thanks, John. Thanks for having me. So we're going to talk about the disease of addiction and how it differs from other substance use issues. We're going to talk about what recovery entails and the way some people have looked at it. And then the real focus is on recovery supports, and we'll get into some technical aspects of 12-step facilitation therapy, which is an evidence-based practice. So that's what John and I agreed to, and that's what we get today. Next one, please. So that's me, and if the slides get shared, which I presume they will, you'll see all these various things that I've done in a 40-year career, including being president of ASAM and one of the founding directors of the American Board of Addiction Medicine, which now doesn't need to exist because you'll find about that in a few slides. Next. So I have a few things that I do in my consulting business, and these are the current contracts that are open, but they have nothing to do with this topic. So next. So again, we're not talking about substance use overall, and I've heard a lot of people say that the term addiction has been replaced by the term substance use, and that is really incorrect. The term substance abuse and substance dependence have been replaced with the term substance use disorder. But substance use disorder and substance use are very different things, because obviously you can use substances for having a disorder. So don't make that mistake. But addiction is not just making mistakes with substances. It's not harmful use. It's certainly not willful misconduct, as the US Supreme Court has ruled. And it's not people behaving badly, which is the way a lot of people experience addiction. They just see the manifestations and they see the behavior. And people are thought to be behaving badly or criminally or sinfully or just inappropriately. And those behaviors can happen, but that's not what the disease is. The disease is something happens in the brain, which we'll talk about, and there's very strong genetic influences. Next slide, John. So addiction is a primary illness. It's not due to something else. It's not due to depression, anxiety. It's not even due to trauma, believe it or not. It often has an onset before age 18. In the most severe cases, clearly before age 15. It's, in most cases, almost always a chronic disease that waxes and wanes throughout the person's lifetime. And so having it wax and wane is what you should expect. You shouldn't be surprised, and certainly shouldn't be angry or blaming or shaming if there is a period of more severity. Just like if somebody has a more severe phase of their asthma or of their diabetes, you wouldn't blame them or shame them, or you shouldn't. It's not a disease of quantity frequency. It's a disease that's qualitatively different from substance use or other things that don't involve addiction. So it's a qualitatively very unique condition, and we do understand a lot of the neuroanatomy, neurophysiology, neurochemistry of it at this point in time. Formerly called substance dependence by the APA in their diagnostic manual of mental disorders, and it's now called addiction by ASAM and substance use disorder by the APA. Next, please. So, one of the first great documents that pointed to the fact that substance use has health impacts that are far outside of what happens with substance use disorder was the Institute of Medicine report way back in 1990 called Broadening the Basic Treatment. And they made the point that we should intervene for people who aren't just at the tip of the pyramid, aren't those relatively few people with DSM, this was DSM-3, abuse and dependence. but there can be all sorts of gradations of use, some of which needs an intervention, some of which doesn't. And of course, there's a bunch of people who don't use at all. And the number there is actually shocking to some people. The number of non-users in our culture, even today, is 1/3. And some of those are people with addiction who are in recovery and are abstaining, but most of them are people who don't use for a variety of health, religious, or just personal reasons. So there's a variety of interventions one can do for risk use and problem use. And out of this report came the whole concept of SBIRT, screening, brief intervention, referral to treatment, for people who don't have addiction yet, or even for people who do. So next slide, please. So addiction is commonly thought to be due to drugs, and it's not. It's not about drugs, it's about brains. That's one of the frequent lines that I use in my presentations. It's the interactions amongst the agent factors, the host factors, and environmental factors that lead to this disease manifesting itself. The environmental factors have to do with culture and family and drug availability and other things like that. What the proscriptions in the culture are against it, where we have this big, legal or moral or other set of social rules that says don't do this, it's not good. And the host factors are in the individuals, and this is the vulnerabilities that have to do with, they're driven by genetics mostly, even though epigenetics is a big thing, whether the genes are actually expressed or not, has to do with environmental factors. The agent factors are really the fact that you cannot get addicted to aspirin, and you can't get addicted to Prozac, and you don't get addicted to penicillin. It's not every pharmaceutical in the pharmacopoeia that can lead to this. And not every behavior is necessarily addicting. So there's something about some of these chemicals that actually what it is that they have receptors in the brain. And when these particular molecules interact with those receptors, they do turn on the reward circuitry, and that begins a cascade of events, which we'll talk about very briefly as we move through. This is not the neurobiology talk, but I'd like to give a little bit just to make clear what addiction is. Next slide, please. So again, it's the interaction of the agents, the host, and the environments. And there is a debate. There's no doubt about it, there's a debate. And a lot of the researchers at NIDA who do research on primates and rodents and what have you, believe that you can give enough of an agent to a non-vulnerable subject, non-vulnerable host, and produce addiction. I believe you need to have vulnerabilities, and I'll stick to that. I believe you need to have vulnerabilities because we know that the vast majority of the public can be exposed to agents and not develop it because they don't have the vulnerabilities. Over 80% of people who use alcohol don't have a problem with it. About 90% of people who use cannabis don't have a problem with it. By that, I mean don't have addiction, don't develop addiction associated with that use. So the agent factors matter, but the host factors really matter a lot. Next slide, please. So the features are engagement with intense unnatural rewards, things like cocaine, which we don't need to survive, things like heroin, which we don't need to survive, things like alcohol and nicotine, which we don't need to survive. So we call them unnatural rewards. The natural rewards, of course, being hydration, nutrition, reproduction, and nurturing of your young. The reward circuitry exists for hugs and for kisses and for sex and for the basics at the very bottom of the Maslow triangle, food and water. But what happens in addiction? People use the substance and behaviors can involve use, but also procurement of supplies, which can be very compulsive and very complex, and again, despite the use of problems. So addiction can be described as somebody who will, in the case of substances, uses and has problems, and then uses more and has more problems, and then uses more and has more problems. It's the failure to stop at stop signs, failure to have stop signs. It's continued use despite problems. It's not using. It's not really problems. It's not learning. It's continuing to use despite the problems, and spending your paycheck on procuring, et cetera, or on gambling, despite the problems you've had. And even if you've had a period of abstinence, that period of abstinence may actually make you more likely to use because it changes your drug hunger. And so after periods of abstinence, it's like, oh, you're back at it again. And nobody should be surprised. But in our culture, people are still like, really? You fell off the wagon? You're doing this again? You're going back to casinos again? You're back going to strip clubs again? What? Well, again, the reason that everybody goes, what? Is because normies don't do this. People who don't have addiction don't go back after problems. They learn that a hand on the stove can cause a burn and you don't put it back there. And they change their behavior. And after long periods of abstinence, they don't go back to something that caused them a problem 20 years ago because they know this is not a safe thing for me to do. Inability to consistently control use is sort of the foundation, the core of this. You try to control your use, you try to dabble, you try to limit it, you try to cap it, you try to avoid problems, and you will lose control and have problems in a periodicity that you cannot predict. So is it every fifth time, every second time, every ninth time that you use? For instance, go to the casino, how many times will you lose 10 grand? Every time? No, but the loss of control happens unpredictably. Preoccupation and the fact that this becomes your number one source of reward, that's not normal. It's normal to bet on a Super Bowl pool. It's not normal to go to off-track betting or online betting and bet every day. It's not, and of course, you don't have to do every day. That's another thing. Not an everyday behavior. You don't have to drink every day or use cocaine every day to have addiction. It's not about frequency or even quantity. It's about what happens when you use. It's about the fact that you have a relationship with your drug. It's about the fact that your drug is front and center for you and it comes ahead of other things, including going to school, going to work, taking your kids to school, being with your partner. It can take the place of sex. It can take the place of everything because it is your salvation. And that's because your brain tells you so. The various cognitive changes where you tell yourself, this really makes music better. This really makes sex better. This makes food taste better. This makes my life better. This gives me confidence. This helps me sell more. This does all sorts of good things for me. And the devaluation of the negative aspects, it's not that bad. I mean, look, my kids are making straight A's. It can't be that bad. Of course, they're making straight A's because they're overcompensating. So the minimization, denial, and the overvaluation, devaluation of cognitive processes that are amenable to cognitive change through cognitive therapy, but they're hallmark with an addiction. And then the behavioral issue of cue response, where we've been able to demonstrate, not me, I used a very imperial we. I'm not a neuroscientist, but the neuroscientists can put electrodes in your reward circuitry. They can put micropipettes to suck out small amounts of neurotransmitters from your reward circuitry. And the things that turn on your reward circuitry are not just drugs and gambling and other things, but the anticipation of them can turn it on. Or you can generalize. And of course, the famous experiments, a couple of them, show a cocaine addict, this research was done in the 80s, we learned about cue response with stimulants, show a cocaine addict a roll of money, and on the outside is a 20, the inside may be nothing, but you show them a roll of money, that makes their drug hunger go through the roof. Okay. The other is drug-related videos. And so research done, you show a nature video, which is neutral. You can even show a sex video, which is a different kind of reward. Or you can show a video of people shooting up or people snorting, and or just a pile of white powder. And the response to visual cues can be very profound. And the research shows that the amount of visual exposure that you need to activate these cue responses that are mediated through your hippocampus, which we're going to talk about in a second, is 0.1 seconds, 100 milliseconds. So we are accustomed and acculturated, and you could say habituated, but the cue response is powerful, and that doesn't exist with other folks. Most people going to a convenience store to pay for their gasoline do that. But people with gambling addiction have a cue response to all those scratch-offs and the lottery tickets there. And if you don't have addiction, you haven't developed that cue response. So again, it's a qualitative distinction between those with disease and those without. Next slide, please. So addiction was defined by the National Council on Alcoholism and ASAM, before it was named ASAM. Back, the committees met probably for a year or two, and then first revealed in 1990. I love the diagnosis. The definition. Excuse me. It includes the features of primary and chronic. It includes the fact that there are genetic, psychosocial, and environmental factors that influence whether it shows up and what it looks like and how it progresses. So it's a biopsychosocial spiritual illness. They didn't say that in those words, but there are genetic, psychosocial, and environmental factors that influence whether it shows up and what it looks like. The disease is often progressive and fatal, not always, but untreated. The disease of addiction generally has an unhappy ending. The features of it that they pointed out are either continuous or periodic, which is really, I've been hinting at that. You don't have to do this all the time. It doesn't have to be continuous. And one of the cognitive changes of addiction is the person with addiction says it doesn't happen all the time, therefore it's not really a big deal. I can do it sometimes, I can do it other times, I can control it sometimes, I cannot. And again, with their overvaluation, they point to the times they do exhibit control, and they undervalue the reality that sometimes they lose control terribly. It's again the cognitive perception they have of what's happening to them. But the impaired control over drinking, preoccupation, I said those were the two core features. I'm going to stick to that. Use to sped adverse consequences. The old DSM-3 for abuse can include that. So the person with multiple OWIs or multiple work suspensions because of positive drug tests, that's not necessarily addiction, but addiction also does have the feature of use despite adverse consequences. Now, this committee way back then talked about distortions of thinking, looking at the world differently than the rest of the world looks at it. Of course, the person with addiction believes their way of looking at it's accurate. They're the last person to have an accurate view of the world and an accurate view of their substance use and its complications and its implications and how out of control it is. And as the first step of AA says, how unmanageable your life is. The distortions in thinking is to have a life that's unmanageable and tell yourself, I can handle it. I've got this covered. Leave me alone. It's not that big of a deal. It's no worse than any of my friends. And so denial is it's not there. Much more common is minimization, which I just gave you a bunch of examples of, or projections. It's not me, it's somebody else, it's something else. Hate to tell you, addiction is not due to a bad back, a bad mood, a bad boss, or a bad spouse, or a bad governor or president. Okay. But it can lead to bad marriages, bad work relationships, bad work performance, bad health, and it can lead to bad government. Next slide. So 20 years later, a group of doctors within ASAM, we didn't have non-physician members then, but we do now, so you're all welcome to join. We're really concerned that the world, the public, policymakers, the media, most medical school graduates had no idea what the primary disease of addiction was. They viewed it as people behaving badly. And we knew a lot about the brain by 2011. We know more now. But in the years leading up to the acceptance of this definition, we probably began meeting in 2008, maybe 2007. And the committee had probably 4 dozen participants at different points in time. But we came up with this one. And it's funny, we've been deliberating and having conference calls literally for years and didn't have anything to show for it. And we said, damn it, we're gonna have something ready to present to the ACM board. And in one call, we came up with this on the screen in about 45 minutes because we had the consensus. The consensus was there, and we knew what we had researched. And so it's primary, it's chronic. It involves not just the reward circuitry, but also the motivation circuitry, the memory circuitry, and even other circuitry. And the frontal lobes is the big part of that, and even the brain stress circuitry. So it's not just about the reward circuitry. Dysfunction in various brain circuits leads to the characteristic manifestations of addiction, which are biological, psychological, social, and spiritual. All of this gets reflected in an individual who is pathologically pursuing reward and or relief through substance use or other behaviors. So what this says is it doesn't have to be substance use. It says you can use for reward or relief. The overgeneralization is that people use stimulants and hallucinogens to give them more pluses, and they use opioids and sedatives to give them less minuses. So Marilyn Monroe was miserable. She used barbiturates and alcohol. Other people are in a high intensity environment, and they, let's take Richard Pryor, for example. Some of you aren't old enough to know who Richard Pryor is, the famous comedian who was freebasing cocaine and blew up his face and had severe burns. He was pursuing a higher reward. He wanted more. So people can pursue reward or relief very pathologically in an out of control manner using substances or other behaviors. We believe this is the first document by a medical association that talked about spirituality as a feature of a disease. And in the wisdom of the current leadership of ASAM, this definition has been archived. It's no longer active. The current one is shorter and doesn't mention spirituality, I think, inaccurately. And let's give the second paragraph of the definition. Next slide. The ABCDE we came up with was abstain, behavior control, craving, diminished, and emotional response, ABCDE. So we didn't say which of these is primary, we just mentioned that they exist. So impaired control, that's the first one. Oh, I'm sorry, impaired control is second. You, even after periods of abstinence, you go back. Okay, you've seen that one. Craving came into DSM-5, which came out in 2013. And we thought that it was important to put craving in our definition, and it made it to the DSM-5 as well. This long bunch of words has my fingerprints on it because I'm very verbose. So it's a lot of words to say what other people would maybe say in a shorter phrase. But I think it really is very descriptive. It's not that you don't see it, it's just that you don't see it as well. A diminished recognition of the problems with your behaviors and your relationships. And that's what most people see in addiction is problems with behavior, again, people behaving badly, relationship issues, and everybody knows except the person with the disease who has a diminished recognition because of the psychological, the cognitive aspects of this. And the dysfunctional emotional response we put in after George Koob, who at that time was not yet the director of NIAAA, this whole issue of the negative emotional state. And we'll talk about that a little bit today. Again, it's not supposed to be a talk about neurobiology, so I have to pick up the pace and talk about recovery and recovery supports. But again, I wanted to provide a foundation. Without engagement in recovery activities, we'll talk about that, doesn't have to be professional treatment. It can result in disability or premature death. Next slide, please. So again, loss of control, preoccupation, and I've already discussed these quite a bit, but again, the issue of motivational hierarchy. What are the things that click your clock? What are the things that make you tick? What are the things that drive you to prioritize things? And the motivational hierarchy gets perturbed, and your drug, whatever your drug is, becomes front and center, and everything else takes second or third or fourth place. There's a defect in satiety. There's enough. There's not the experience of enough. Keep going. And I think it was Mark Twain that talked about smoking. Stopping smoking is easy. I've done it 100 times. That's the inability to stay in. The one about satiety is one is too many, but 100's not enough. And that phrase is said in the rooms of AA. That makes sense. Again, enough just doesn't happen. And it happens again with gambling, with sex, with eating, with exercise, with purging, with spending, with work, with whatever. Next, please. Okay, so it's more than just reward circuitry. It's the memory circuitry that involves conditioned cue development. It's the motivation circuitry that makes your drug number one for you and involves the compulsion because you're making it number one, the loss of control through the frontal lobe issues, and the whole issue with emotional and stress circuitry. Everything feels awful with the negative emotional response. Again, there's a lot more detail in the ACM definition of 2011 and in many articles written by Dr. Kub and Dr. Volkow and others. But everything seems stressful. You're in this negative state that is relieved primarily by further drug use. The brain stress circuitry gets involved, not just the hypothalamic pituitary adrenal axis, which produces the endocrine stress response that we all learn about now in middle school. Okay, if I was given the neurobiology talk, you'd learn a lot more about each of these, but and I think maybe we don't even have the basic slide about the reward circuitry. Next slide, please. Or maybe we do, but we need to go through and no, we don't. So basically the reward circuitry exists so that hydration, nutrition, copulation are all primary behaviors, front and center, salient things to do. I mean, you could do a million things today, but eating and drinking is important, and the species will not make it if you don't reproduce. And so there are certain things that turn on a particular area of the brain, which involves the nucleus accumbens, the median forebrain bundle, and the ventral tegmentum in reverse order. And the dopamine released produces a cascade of events, including a cognitive awareness at the level of the cortex, where you're aware of the reward. And so that's the thrill of champagne that you notice, and it makes you want to go back to it. But the difference between the person with addiction and the person without addiction is the person without addiction can have their reward circuitry turned on and it's a one-off. So what? I had a big squeeze of dopamine from my nucleus accumbens. That was great. Not going to deny it was great. Yes, that was an orgasm. Wasn't that great? Okay. That is something I think I might want to do again. Okay. But the cascade of events doesn't get triggered. And we don't know what flips the switch. And that's going to be a Nobel Prize one day. But how is it that in some people, the switch is flipped and you recruit these other areas, the frontal lobes to inhibit you less, the hippocampus to have the powers of memory stronger, the amygdala to have you prioritize. And that's the difference. Okay, and let's talk about recovery. The ASAM definition, a process of sustained action. That's a nice one, sustained action, that addresses all of the biopsychosocial spiritual disturbances in addiction as was defined by the same general committee. Recovery aims to improve quality of life. And you want to have balance and healing in all aspects of health and wellness while addressing the ABCDE of addiction. And you want to recognize, instead of being clueless, instead of having diminished recognition, you want to be honest and, do a first step and do a fourth step and be aware of your unmanageability. And you want to deal more effectively with your emotions. So it was a very sort of elegant, I think the group did, bringing the ABCDE of the definition of addiction into the whole concept of recovery. And next slide. Yeah, let's do the abstinence one. Which I don't care which order they're in. These two slides. The Betty Ford Institute, way back in 2007, had a consensus panel, published their results in JSAT 16 years ago. A voluntary, maintained lifestyle characterized by sobriety, health, and citizenship. The functioning in the community and the functioning in your primary relationship with your partner are really keys in this. Now, Freud said love and work. Well, that gets right into this, okay? And there was another group in the first decade of this century over at Faces and Voices of Recovery that did research on recovery language. And what they were trying to do is find out what are the words to use that will be more attractive to people and get more people to try to enter recovery. And interestingly, brain disease is not language that clicks anybody's clock. That doesn't get people going. And loss of control doesn't get anybody going. But the language that was attractive and resonated and got people to say, okay, yeah, was to say that people in recovery should say the following. I'm in long-term recovery. Did you hear that one? Not a week, not a month. I'm in long-term recovery. For me, that means that I haven't used in X period of time, self-disclosure, and I'm able to function better in my family and my community. What it means for me is that I have, I have a sustained recovery. It means I haven't been using for a good while. And of course, some people can abstain for years and decades. I have an associate in Wisconsin who now has been sober for 63 years. And he's still working in the field, and it's a vital guy. So lifelong recovery happens. And that's a message that so many people now are forgetting in this world of harm reduction. Let's just give up on trying for recovery. Let's just give up on it and say, let's just reduce harms. And that's about all we can expect from the treatment and recovery system. That, I think, is an insult to all people with addiction and all people with professional training and counseling. People in counseling should not be replaced by harm reduction technicians. Even though harm reduction is an important concept and should be incorporated into everyone's work, it's not sufficient. And we shouldn't say that's good enough. We can do better. Citizenship, health, again, love and work are really a key to all this. So abstinence, what did ACM say abstinence was? It said that you were not engaged. I think it's the previous slide, John. Nope, so we'll go 2 ahead. You did a double click once. Nope, so we'll go forward 2 or 3 now. Intentional restraint from the pathological pursuit of reward or relief that involves use of substances or other behaviors. You stop doing it pathologically. Does this mean you could use, well, if it's eating, obviously you're not going to stop eating. And if it's sex, we're not expecting you to be, celibate the rest of your life. You're not going to pursue it pathologically. You're not going to do it in a way that's out of control. You're going to do it in a way that's consistent with being functional in your family and in your community and at your job. An unhealthy engagement with a behavior, which again can be substance use or can be something else, which has in the past been a manifestation of addiction, would constitute a loss of abstinence. But it doesn't mean that if you're on an opioid, which maybe even you were addicted to in the past, such as buprenorphine, it doesn't mean that you're not abstinent. You can be abstinent while on medications for opioid use disorder, which was sort of the point of creating the definition of abstinence. Next slide, please. So recovery, let's talk about recovery. Next slide. Talk about treatment, I'm sorry. But recovery really is a process, and recovery is very personal, and recovery involves behavior change first. If you don't stop using you're not amenable to the other treatments. One of the slides out there in the world says that pharmaceuticals work on the midbrain and psychotherapy works on the cortex. And that's actually a pretty good summary that we use talk therapy to the parts of the person's brain that are amenable to change through talking. And that's the cortex where consciousness happens. But there's unconscious craving and there's unconscious drives in the amygdala. You don't have to have a connection to the cortex for the amygdala to prioritize something. We don't think about food and water being so essential, but they are. And recovery is a process that involves behavior change, cognitive change, emotional change, spiritual change, and it involves no longer pathologically pursuing reward over relief. The final comment on what addiction is and what it is not. In many, many cases, addiction begins as positive reinforcement and evolves as the disease progresses to negative reinforcement, meaning at first, I want to get the positive reinforcement of reward. I want the buzz. I mean, who the heck doesn't? But over time, as the brain changes and as the negative emotional response sets in, you're physically dependent, you're miserable, and you use drugs to take away the pain that you have in your brain, which is a vicious cycle and almost interminable because, again, what you do to get rid of the negative emotional response just creates more of the negative emotional response. And the only way out of that cycle is to abstain and stop feeding the addiction process and then go through the withdrawal process and then build in things to substitute for your drug. So abstinence is the standard treatment goal, but 95% of people will use again after an index episode of professional treatment. But that doesn't mean a whole lot. It just means get back up on the horse and start riding again. And so the goal of treatment is to stay engaged, to reconnect with the world, and to keep going to meetings, keep going to treatment, keep staying on your medication, do whatever it needs. It's not a 30-day deal, whether it's medication, counseling, AA, or anything. It is not a short-term intervention for a chronic disease. So again, people who are on meds for addiction treatment are still abstinent. So treatment can include professional interventions and non-professional interventions. So rehab led by professional therapists plus pharmacotherapy are the professional aspects of it, and the recovery supports, which is going to be our focus here, will be another 10 intense minutes talking about that, which is really why I wanted to give this talk. I guess I've given the biology talk so much it just kind of flows. And I don't think you mind that you got that education, but and it was in the title, but I overemphasized it much and didn't save enough time for recovery supports. But don't worry, we'll get into it. Next slide, please. So addiction treatment defined by ASAM as, next, and this has been archived as well. The policies they're using are ones that are actionable on the Hill this session, and they basically archive everything else, which is not a way that I would approach it, but it's planned, it's intentional, it's not random, it's not accidental, it's not quirky, it's planned, it's intentional, and you aim to improve the health, behavior, and functioning and family life of the person who has addiction. And you want to enable them to attain sobriety, physical, spiritual, and mental health, and maximum functional ability. Functionality really has to be the goal of everything we're doing. That's that one. Professional treatment is not random. Next. Delivered to a person with addiction, so have a diagnosis. And then, of course, you can also offer services to support the family. But the addiction professional obviously can be a physician or non-physician of various flavors, but the person should be licensed or certified in their jurisdiction to show that they have professional training. Again, they're professionals. They're not snake oil salesmen, and they're not just working at a carnival. They're doing something professional like you guys do every day with all of your clients. Okay, next slide, please. So again, the interventions are a variety of recovery and peer supports, which can complement professional treatment, and that can include smart recovery as well as 12-step groups and working with a recovery coach. The professional treatment, again, is psychosocial interventions and therapies of various types and pharmacotherapy, which should be integrated with each other. And therapy actually is very helpful for people continuing to stay on pharmacotherapy and not dropping out. And that's a big problem with all addiction treatment, is people drop out of one or both. And you need to keep the treatment condition in place, I would say, for 2 years to get your best results. Next slide. So again, there's a whole bunch of versions of 12-step. It's not just AA from 1935 or Narcotics Anonymous from 1950, I think. Not just Cocaine Anonymous, which developed during the cocaine epidemic of the 80s and early 90s, not just Heroin Anonymous, which has come up during the opiate epidemic that began rising more around after 2000. There's behavioral addictions that have 12-step groups, and the basic structure is about the same. But it can help any human being because it's a good, healthy way to live. Next slide. So, how do you support somebody's recovery? Well, one thing is to not sabotage it, and you want to make sure that they have ideally a safe place to be that's supportive of recovery and not critical of it and not sabotaging of it, not threatening to it. It's not an environment that's full of substances or people selling them or using them or giving them away. It's not an environment where ongoing abuse is happening. And so recovery environment really matters a lot. And peer supports really matter. Peers that you meet through AA are actually a recovery coach. And recovery coach it's kind of in a gray zone. Is it professional? Is it certified? Does it require training? Does it get Medicaid reimbursement? I mean, it's getting to be sort of more professional, even though their training is minimal compared to a professional therapist. But at any rate, all these things can be very supportive. I want to have a few slides here that are coming up next. It's a supplement to professional treatment. We call it self-help, but it's not self-help, it's peer support. Self-help is just go meditate on your own. This is not you solving it by yourself. This is help amongst peers. It's interaction with others. Next. And this policy was written way back in 1997 by a group that involved the addiction psychiatrists and ASAM and the APA, the psychiatric version of the APA. And what did it say? It said that it's really important. Next slide. But it says it's a complement. It's people should be treated by qualified professionals following practice guidelines and patient placement criteria. But self-help groups should be recognized as very valuable community resources. And insurers and managed care organizations should be aware of the difference. And a treatment plan that comes from an insurance company should not say go to AA, because that's copping out. I mean, yes, they should, but that bypasses what's the professional component of treatment that's needed. And the insurance company shouldn't be trying to save money to say go to something that's free. It's 12-step meetings. It's not a substitution for professional treatment. It's a complement. That should be an E, not I. A complement to treatment directed by professionals. Pretty good thinking back. How many years ago was that? 26, quarter century ago. Next slide, please. Okay, so in the ACM definition, long version, which is now called ACM description of recovery, which I think is not archived, it does say self-management is helpful, but mutual support is also helpful. And peer support can be found in various self-help activities that optimize functional outcomes and health status. Yay! Next slide. So the best solution comes from bringing together self-management, which you can do on your own, through professional help and mutual support. Three-legged stool, three-legged stool. Next slide, please. Okay, recovery coaches are these, I think Wikipedia did a fine job. Sometimes they do a botched job. This is a really nice job. It's not therapy. You don't address the past. You're not doing trauma healing. You don't really talk about feelings. You talk about the person shares their experience. And so if you look at Yalom's Curative Factors of Groups from his famous book, Theory and Practice of Group Psychotherapy, it's identification, it's what's the word? Sort of an S. You're learning through seeing somebody else do it. So it's a sharing of life experience. And the recovery coach shares their life experience and says, this may be helpful to you, it may not be. So it's a surrogate kind of learning. So the recovery coaching is action-oriented with an emphasis on the here and now, somewhat on reaching future goals, but not dealing with the past. And again, recovery coaches now do have training, and some are certified in some jurisdictions. Next. Now, why not just do professional treatment without all the 12-step groups? Well, professional treatment for a lifetime is not what our insurance world is built around these days, unfortunately, but it should be. You should keep the treatment condition in place for a lifetime, just like you do for cancer and for diabetes. You don't give somebody insulin for 3 months, or you don't give somebody an antihypertensive drug for 30 days and then expect them to have long-term functionality. You keep the treatment condition in place. The 12-step groups promote recovery. They're not a substitute. Okay, next. We're going to talk about 12-step facilitation in the 4 minutes before the Q&A. Most professional programs do suggest that you go to AA, and don't just say it sucks without trying it. And you try different groups and generally have some experience with the sponsor-sponsee relationship before you're done. And I would encourage you that if your IOP doesn't do this, it should do this. You should have people try AA because it's going to be available to them the rest of their lives, and try out a temporary sponsor relationship just to see what it's like and report back on it. So next slide, please. So TSF is an evidence-based practice. It was one of the 3 forms of therapy studied in Project Match. Manuals were developed by NIAAA. Motivational enhancement manual may have existed already. CBT manual, certainly, you know, that's standard stuff. But TSF is very interesting, and it was developed and because they wanted to have that as one of the components in Project Match. The hypothesis of Project Match was that you would match people to a type of treatment based on some pre-treatment variables that you would assess in the individual. Project Match failed with its hypothesis because all 3 work for everybody. That's the good news. All 3 work for everybody, except one little thing you're going to see in the slide. So next, so what is TSF therapy? It involves not just saying go to meetings, but probing and interacting with the person about what's it like and helping them make AA and sponsor relationship and step work useful to them. You actually ask them questions. You get them to tell you what are their barriers. And you also talk about things beyond just the clubhouse, doing chores and doing retreats and dances. The data is that people who do meetings and steps plus clubhouse activities, plus is volunteering around the club, plus doing beyond clubhouse activities, they have the best results. So people that go to a convention or retreat actually do better. And people that volunteer to shovel the snow or mow the grass at the clubhouse actually do better. And people who volunteer to clean the coffee pot do better than those that just come to meetings. And of those that go to meetings, those that talk do better than those that don't. So participation is better than attendance, but attendance is better than nothing at all. So attend until you feel like talking or feel comfortable talking. Go until you like it. Classic line in AA. How long do you go? Go until you like it. So the behavior of showing up, but the therapist in TSF probes and engages and does checklists and does daily report sheets. So next slide. So what can you do? You can, TSF integrates AA concepts into therapy, and you can do it even without really doing TSF. So you can bring AA concepts into your therapy, but can you really handle this or not? Will willpower really do this or not? Have you noticed that you don't always control this even when you try? The issue of rigorous honesty, the issue of openness, those can be brought into any therapy of a person with addiction. Next slide. And it's also important to realize that some people really do have trouble with social anxiety, and treating that is an important part of the recovery plan. And because if you don't, they won't show up at all. So a buddy system can help, not just psychotherapy or pharmacotherapy. A buddy system can help. Back when I got into the field, first friends was common in AA, and it's not as common in my communities anymore. Recovery coaches have sort of taken over the role of the first friend to take you to your first meeting. Next slide. So again, in the manual, it says that when you finish the phase of treatment, your termination session should review how did it go and what trajectory will you have when you leave. So are you really doing these checklists every day? Are you writing down your number of sober days on the calendar? Are you journaling your urges? Are you writing down your slips? Do you keep a record of what you're reading? Do you make sponsor contacts and put them in a journal or a calendar? Are you working the steps or not? And so at the end of a 12-week course of TSF, people should be used to these daily checklists and then use them as they move forward. In the next slide, How did you like it? Oh, I'm sorry. This slide says, what did this slide say? Oh, some 12-step meetings may not be open to people with MOUD. I think all of you know that. Sometimes people keep quiet the fact that they're on meds because they'll get so shunned by the people in the group, which is incredibly unfortunate. It's still the truth, though. It's very hard to talk about it, which is why there's Methadone Anonymous meetings now, because people going to a meeting and saying they're on methadone can result in the group saying your recovery is not good quality recovery. Next slide, please. Again, what's it been like for you to do these things? So again, now this assumes that the therapy is ending at 12 weeks because that was the research design. Nobody's therapy has to end at 12 weeks. Nobody's therapy should end at 12 weeks. But periodically, again, probing, what's it like for you? Is it going well for you to get a sponsor? Is it not going well? Do you need to get a new one? You know, did your sponsor relationship peter out? Do we have to think about a new sponsor? Do you call people? Do you meet them outside of meetings for a coffee or pie or whatever you meet them with for? Do you go on long walks with people you've met at AA? Do you exercise with them or go to the gym with them? Do you do the other stuff? Do you go to the AA dances? Do you go to the AA camping trips? Do you go to AA kayaking trips? Do you go to AA conventions in your state? What do you do? These things can be probed of any patient. So next slide, and I think we're about done. What can you do as a therapist? Let's jump over this one. What can you do is you can just be aware of it and bring it into your therapy with your patients. Have a list of AA available for them. Have a list of NA available for them. And then use the technology of TSF to put it in your chart, put it in your notes, make them know that you're interested. If you tell somebody go to AA and that's it, and you never ask, they'll know that you weren't serious, you didn't really give a damn. But if you keep asking, how many meetings have you been to since we last met? What's it like for you? Oh, you got hit on at that meeting? Oh my God, you might want to go to a women's meeting only. You deal with the barriers, you deal with the pitfalls so that they can have a successful experience with it. And if there's somebody in your community who you know wants to be a first friend, it is willing to volunteer to take people to their first meeting, have that available in at the side of your computer to give that name out. And if there's recovery coaches in your community, or it's a grant funded program for recovery coaches, utilize it and have a recovery coach meet with your person to share that shared experience of what their own life has been like with their addiction and with recovery. And so use recovery coaches. So I think that's what the next slide says. This was taken directly out of the manual, but next slide. Does it improve treatment outcomes? There's a whole bunch of slides when you get the slides on research into AA. We're not gonna have time to talk about research into AA, but I talked about what recovery supports can be through a 12-step group or not, the use of recovery coaches, incorporating in your therapy. That's what I really wanted to convey. Hopefully you feel like maybe you could do some things differently than you've done so far in your career. Maybe you can really incorporate these ideas into your work on a daily basis. You can. It's not hard. I mean, it's just not hard. Let's call it a wrap. Let's have a few questions.
Thank you so much, Dr. Miller. I wish we had 3 hours with you today. We'll be sure to schedule another webinar with Dr. Miller soon. A couple of questions. Dr. Miller, if it is determined one addiction causes another, for instance, social media use causing alcoholism due to depression or craving attention drives anorexia, or drug use for weight loss, do you treat the primary addiction or both?
I do not have a concept of primary addiction, secondary addiction. It's all addiction. Addiction can manifest itself as an eating disorder. It can manifest itself as, actually, in some cases, I don't know if I really believe that compulsive self-injury is addiction. Some people think that's the case. Some people treat self-injury with naltrexone. I don't know, but certainly exercise, food, sex, there's a variety of things that you can pursue those rewards very pathologically with impairment of control, preoccupation, and salience. I mean, so that's addiction for me. And so one addiction doesn't cause another. Addiction is addiction. You have addiction because the switch was flipped and your brain circuitry functions differently, and you do have cue response, and you do have impaired control from your defective frontal lobe functioning, and you do have salience through your enhanced amygdala activity. So you have addiction. Once you get a handle on alcohol, cocaine can take over. Once you get a handle on gambling, pot can take over. And for almost everybody, nicotine is going to kill you more than anything else. So it's not that it led to the other addiction, it's more like whack-a-mole. You knock down one and the other rises up. Classic eating disorder patients in addiction treatment with alcohol abstinence. When they're not getting the reward through their drug or alcohol, they get their reward through their eating disorder. So it's like whack-a-mole, but you deal with everything at once. You have a unified approach to it. How do I do it? Addiction is addiction. Next question. That was a great question. Perfect question.
Last question. What are your thoughts on smart recovery for those who have really tried AA and do not, quote, like the God piece?
Well, there is a great book called AA for Agnostics. And so there are groups out there where atheists use 12-step principles that don't involve God at all. The higher power is the group. Smart recovery is another tool. It's an important one, and it's very helpful for some people. It does have this professional facilitator that doesn't charge money in most cases. So smart recovery groups are often facilitated by professionals who volunteer their time. AA isn't that way. Smart recovery is very helpful for some people. Here's my overall statement. Smart recovery has not won in the marketplace of ideas. By that, I mean, there aren't as many smart meetings as there are AA meetings. And it's been around for decades. One of the founders is a colleague of mine in Madison, Wisconsin. It's great. It's got great theory. It helps a lot of people, but it's not as ubiquitous. It's not available when you're on vacation. It's not, I mean, and again, it requires, from my understanding, some sort of facilitator of the group. I'm not going to say anything bad about it. I'm going to say that on a quantitative basis, a hell of a lot more people recover through AA than through smart recovery. And smart recovery, again, it should be more ubiquitous. It's not. So it's an important thing out there. So some people love it, some people don't. And there's a lot of people who don't like AA for a whole bunch of reasons. But if you're doing TSF, you're going to get to all of those reasons and work on it and go try a different meeting, get a new sponsor, do this differently. I mean, some people prefer Zoom AA because of social anxiety or whatever. I mean, there's so many ways to skin a cat. There's so many versions of 12-step. Yeah, I personally do not care for AA meetings that end with the Lord's Prayer because I think that's way, way too excluding of people that don't have the Christian orientation. But the Serenity Prayer is very, secular, humanistic, and is good knowledge for all of us, or a good approach to life. I hope that some of you who were skeptical of AA yourselves through either your own experience or hearing so many of your patients tell you that didn't work for me, I hope you'll give it a second thought. I hope you will realize that recovery coaches have really proliferated, and SAMHSA has given so many grants to so many communities to establish recovery coach programs. Hopefully that'll be sustainable after the federal subsidies run out. But recovery coaches are great, and they found their way into addiction research by having recovery coaches available for the emergency department buprenorphine induction programs, where you start buprenorphine in the hospital emergency room after the overdose. Instead of waiting a week or a month or whatever, you're telling somebody, go here for your buprenorphine. You initiate it right in the ER, but then you have the recovery coaches brought in as well to share their own experience and to be a person that the individual can call and use as a first friend for AA, or just never go to AA, but just be a peer. And so I hope that you are more aware that these things are there for you. You can use them anytime. It's a low barrier entry for you as a therapist. So, okay. Thanks for having me, John.
Hey, thanks for your time, Dr. Miller, and thanks everyone for your attendance. We'll be back again next month, and we'll schedule Dr. Miller again very soon. So thanks everyone. Have a good afternoon.
Okay.